16 different member organizations that you can see here on the slide from across the vision health space and others, including provider groups, patient advocacy groups, research organizations, and patient support groups as well. And we really serve as a convener of these organizations, ensuring that we're all working together to get information out to vision patients, to clinicians, and to their so everyone should have received a folder when you checked in. In those folders is a variety of educational resources and flyers that we put together along with the input and experience and expertise of our member organizations. These materials, as well as others, can be found on our website. You'll find our website right here. We're also on Facebook and Twitter and or X, however you refer to it these days. So if you're on either of those platforms, feel free to give us a follow and share with your friends and families. It's the best way to, stay up to date with our new resources, as well as any events, whether virtual or in person, like the one this evening that we'll be holding. So I do want to hand it over to Dr. Ramesh for his presentation.
Yeah, thanks for having me. My name is Deepak Ramesh. I am an oculoplastics surgeon, meaning that I did my training in ophthalmology and then I further went on and did orbital or plastic surgery. So thyroid eye disease is really a passion of mine. I spent a lot of time taking care of patients with that when I was in training at UCLA. When I was a fellow at UCLA, that's when Tepezza was in its infancy. So the phase 2, phase 3 trials were going on. And I remember, being in bed in the middle of them and going and pulling a chart from patient number 23 and saying, oh, hey, we need this data point and we need it now. So I've been involved, and it's really interesting to see how thyroid eye disease has really been transformed because, again, as recently as when I was in training, we didn't have treatments for patients who had active phase of disease. We said, okay, you have TED, come back in 3 years and maybe we'll have some surgery for you. But otherwise, it was just hand holding and teardrops. So it's really great to see that we have some targeted medicine address the disease at a fundamental level. So my office is at Set and in Leamington. I take care of patients from all over the place, so happy to answer any questions. Today, I wanted to talk about thyroid eye disease from a few different aspects. So first, we should understand, why does it happen? What makes it worse? Why am I at risk for it? What will happen in the future? Look like, so the clinical manifestations, medicine that we can use to treat TED, surgeries, and then what we want to do in the future and what we're working on right now. So why does thyroid eye disease happen? So thyroid eye disease really should be termed autoimmune thyroid disease that affects the orbit, because it's not just Graves', it's not just Hashimoto's. Any autoimmune antithyroid antibody cross-reacts to the tissues inside the eye socket. So it's not even really an eye disease, it's an orbital disease. So the orbit is all of the tissues that are inside the bone of your eye sockets. So the eye is actually really minimally affected with thyroid eye disease. So it's the orbit as a whole. It's the fat, the muscles, the connective tissue, everything around the eye affected. An autoimmune disease, auto meaning self, immune meaning your body's immune system, is overactive and it's attacking your own body. So there are a variety of autoimmune diseases that you might be familiar with: lupus, rheumatoid arthritis, all kinds of things. So the key is that this is all starting in your bone marrow. So your bone marrow, or other sites in your body that make antibodies, which are supposed to fight bad things, attack your thyroid gland and they attack your orbit. So the thyroid hormone really has very little to do with what's going on with the inflammation behind your eye. It's the antibodies that are in your blood. So the main source are these antibodies that are floating around, and then they happen to attack your thyroid gland, and that can make your thyroid gland make more hormone. It can block it from making hormone. It can make your symptoms hyperthyroid. It can make you hypothyroid. It can make you different points in your life. So these antibodies can change. They're constantly in flux. So what the hormone itself is doing is not really that important as far as what the eye is doing. It's the autoimmunity. It's the actual stuff that's in your blood that's causing this. So that's why sometimes we need treatment despite people being well controlled on methimazole or thyroid taken out of those things. That's not as important because the eye socket happens to have these receptors that respond to these antibodies. Why? I don't know. Those antibody receptors happen to be on different parts of the body. They're eye sockets, they're in your shins, they're in places we wouldn't expect. So for some reason, this cross-reactivity happens. So about half of people who have Graves' disease or some sort of autoimmune thyroid disease will end up developing the eye problem as well. And it's, again, because of the cross-reactivity. So most people in the United States who have thyroid eye disease happen to be hyperthyroid. They have Graves' disease. But there's a large number of people who are also Hashimoto's. They have low, and some people who never have any hormone problem, but they still have the positive antibodies. So just because your hormone is high or low or whatever it is, I totally expect it to change at different points in your life. Really, the antibody level is the most important thing. And one of the common missteps that I see, because patients often sometimes take a while to get diagnosed, is that their primary care or their endocrinologist checked a TSH. And they said, oh, the TSH was normal, I don't have eye disease. But you can have a normal TSH because you might have been treated the fake hormone problems and still have elevated antibodies and still have an eye problem. So it's important really at the beginning to check the antibodies and see, do I have this autoimmune condition? And fortunately, the disease is a self-limiting, mostly not super severe problem. So while it's extremely debilitating cosmetically, functionally, psychosocially, very rarely do people go blind from the disease. People can have things that make them unable to function and work. They can have double vision, you can have light sensitivity, all those things there, and we'll talk about that. But rarely do people actually lose vision from thyroid eye disease like they might from glaucoma or other problems. So most people are in the middle. This is from a study that with my research group at Wills, we published this last year. And really, this shows that most people who get thyroid eye disease are female. So the dashed lines are female patients, the solid lines are male patients. And this is pretty common for most autoimmune diseases. For some reason, female patients are more likely to get autoimmune diseases. And the peak is right in your 40s. So it's not a disease of really young patients, and it's not really a disease of really older patients, although you have people along both ends of the spectrum. It's really people in that prime life where you're getting this problem. And that's the age where people are advancing their career, families, find a spouse, all these things. So it's important to recognize, even though someone might have, quote, mild disease, it can still be really debilitating psychologically and career-wise and socially and all these things. So Rundle's curve. How many of you have heard of the phrase Rundle's curve? Rundle was an endocrinologist. He studied thyroid eye disease in the 50s, or 1945 is when he published this paper. These are the original patients that he looked at. And this is the proptosis measurement. And he just took patients and he followed them over about 3 years, and he measured their proptosis to see how did their eye measurements change over time. And what he found was that it gets worse, and then it stabilizes. And it gets worse up until about maybe 2 years into the disease. 18 to 24 months is when the peak of the disease is. After that, it gets a little bit better. Some people got a lot better. Some people got just a little bit better. But everyone stabilized, and it tended not to get worse after that. That's Rundle's curve. When you develop thyroid eye disease, it's going to get worse for about 1.5 years, 2 years. Then it'll a little bit better, maybe 10% better, and then it'll plateau. And it's not really going to change after that. So our goal is to get you here back to there. And we don't know where you're going to end up when you're at the start. Some people end up really severe, some people end up really mild. A little bit of, we have to wait and see. So there's some inherent uncertainty in that. Common question is, once we've taken care of someone's thyroid eye disease, we've done medicine, we've done surgery, everything, and they're good. They ask, what's the chance that this is going to happen again in my lifetime? 5 to 10%. If you're a non-smoker, the risk of this reactivating in your lifetime is 5 to 10%. Pretty unlikely. So Why is this disease like this? Again, it's one of the unanswered questions about thyroid eye disease. It's not like diabetes or hypertension where once you have it, forever and you always have to be on treatment. It goes in phases and it might get better, it might get worse, but usually it stabilizes after a certain time point. So how do you know if you're at risk of having severe thyroid eye disease? Number one, if your antibody level was high at the very beginning of your diagnosis. So one example is the TSI. If your TSI was over 500, then data shows that you might be at risk for more severe thyroid eye disease. Your levels, your T4 levels, if they're really off when you're first diagnosed, that might mean that your thyroid eye disease is more severe. Your genetics might have something to do with it. So this is a study, again, that I did with my research group at Wills. We took patients with TED in India, and then we took a bunch of patients with TED in the United States, and we looked at how they presented. And even though the Indian patients had thyroid eye disease, the ones in the US were much more inflamed and swollen and had redness and all that stuff. So there's something about genetics that impacts how people's thyroid eye disease appears. We don't know too much about why, but we know that it is a factor. What you eat can affect thyroid eye disease. There are bacteria in your gut that look like thyroid receptor. So they make these proteins that might be a target for these antibodies. And if you have all this target, then your immune system gets revved up and it says, I need to make more antibodies because there's something in this person's gut that I need to attack. And then your eyes get worse. So your gut might have something to do with it. Smoking is the worst thing that anyone with thyroid problems could do, because we know that those, chemicals that you get from the cigarette smoke, less so marijuana, mainly tobacco smoke, but those things can really, really worsen your thyroid eye disease, and it's really linked to the number of cigarettes that you smoke. So the more you smoke, the worse your disease is, less well you respond to treatment, and then if you stop smoking, your disease gets better. So it's also, fortunately, the main reversible risk factor that we can, to some extent, control. And then vitamins. So selenium and vitamin D are found to be at lower levels in people who have Graves' disease and thyroid eye disease. So if you are deficient in selenium or you're deficient in vitamin D, then you might have worse problems. And why is that? Our body uses vitamin D and selenium to make stuff that fights the immune system and these autoimmune, problems. So it uses up a lot of selenium and it uses up a lot of vitamin D. And if you don't have that supplemented in your diet, you're not in the sun, you're not getting it in your food or in the soil, then your eye disease might be worse because your body doesn't have the resources necessary to fight the disease. And radioactive iodine. So a lot of people have had radioactive iodine. Just because you have TED doesn't mean you should radioactive iodine, but what we know is that if you kill the thyroid gland with radiation, it's going to release a lot of antigens or targets into your body, and then your immune system gets revved up. So the way to counteract that is if you give someone steroids right before they start that radioactive iodine treatment, and you give it to them for about 2 to 3 months, you really reduce the risk of having their eye disease get worse, or them developing eye disease even. So those are a lot of things that might cause someone to have thyroid eye disease. We don't exactly know the details. We can't predict, this person got diagnosed with hyperthyroidism, they're for sure going to get eye disease. But we know it's going to be more likely if they're female, in their 40s, they're a smoker, they had really high antibody levels. Those are people that, I will really keep a close watch on. So what does thyroid eye disease look like? I don't have to teach you. You're living with it. Bulgy eyes, redness, pain, your eyelids are more open, double vision, all of these things. But I like to divide this into 4 main categories. So first is the surface of the eye. So ocular surface means how the lids and the tear film interact with the cornea, the surface of the eye. You can have eyelid changes, muscle changes, so the muscles that move the eye, and then the orbital soft tissue itself. So the fat, the muscles, all the stuff that cushions the eye. Because the eyeball swims inside a pool of fat inside the socket. So all the stuff around it can be affected. So ocular surface, when you really the most common manifestation of thyroid eye disease. More so than any of the other noticeable things like bulging and pain and double vision and all those things, almost everyone with thyroid eye disease has dry eye. And the dry eye can manifest as grittiness, wateriness, light sensitivity. All of these things people can have even though you take teardrops, even though you take steroid drops or Restasis and all those other things. The reason it happens is because there's two groups of dry eye. At the top, we have people who are in their active phase of disease. So active phase, meaning your body is making all these antibodies. These antibodies are going into your eye socket and causing all this inflammation, right? So that same antibody is actually in your tear. And when you will now attack your cornea and cause inflammation and dry spots all over the cornea. And you can't really do anything about it because it's in your blood. So people who have early active disease and they're inflamed have pain, light sensitivity, and all this stuff because the surface of the eye itself is super inflamed and has nothing to do with how well your lids are closing or how bulgy your eyes are, because your body's attacking itself and its cornea. So if you stain the eye, a dye, you can see all these little dots are spots of inflammation along the eye and the cornea. Those are people who are relatively early on in their disease course. People who have had disease for a long time, or who are very, very bulgy, or whose lids don't close, different of dryness. So here, we can see the staining really is at the bottom of the cornea where the lids aren't able to meet. So that is the gap where your lids are open when you're sleeping at night. And these patients have dry eye that's really worse in the because at night, your eyes are open, you have an overhead fan or something like that. And this is treated much differently from this. So this, you have to treat the actual disease itself. You have the here, you can fix the eyelids, you can fix the bulging, you can make the eye more moist. The things are options. So people don't really recognize the difference between those two kinds of dry eyes. And if you don't treat it the right way, it's really hard to be able to fix the problem. Most people who have thyroid eye disease have eyelid change. So eyelid retraction means that the eyelid, instead of being just touching the iris, which is the colored part of the eye, when you do back inside the eye socket. So the upper lid is too high or the lower lid is too low. And if you see white space around the colored part of the eye, either above or below, that's potentially a sign that you could have thyroid eye disease. That's really the most common manifestation. Lag ophthalmos means the lids don't close. The reason the lids don't close is because the muscles around the eye are stiff. And one of those muscles is the muscle that raises the eyelid. So when that's stiff, it can't relax and the lid doesn't close. And for that same reason, if you look up and then you look down, sometimes that muscle, again, it's stiff, doesn't allow the upper lid to come down as well. So that's called lid lag. You might have heard doctors talking about that. So when this patient is looking down, this upper lid lags behind the other lid and it's not able to go down all the way. So why is all this important? It means you're not blinking well. So if you don't blink well, the eyelids are like when you do the eye. So every time you blink, which is once every 6 to 7 seconds, your eyelid is supposed to squeegee the surface of the eye clean. It's supposed to wipe off all the debris, supply it with a new fresh layer of tears, and get rid of all the junk. And if you're not blinking appropriately because you have one of these problems, then it's hard to put a teardrop in every 7 seconds, right? So you're going to have all symptoms. The extraocular muscles, they are the muscles that surround the eyeball. So there are these kind of grayish, silverish blobs that surround the eye socket. You can see this one is really big. So that corresponds to the muscle underneath this eyeball. So the muscles get big. They're supposed to be probably this size. And when they get big, sometimes 3 or 4 times the size of what they're supposed to be, they're stiff, they don't relax. So they work, they still are able to squeeze, but they're not able to let go. So what happens when this is really big is it just pulls down and someone tries to look up, they're not able to because that muscle is just so tight. So this is an example of just one muscle that's big. People have all 4 muscles that surround the eye that are, quite large. And when that happens, that's when you have double. when you do pain, when you move your eyes to the side or up and down, and that can be very irritating. Double vision is really, really, really hard to treat in thyroid eye disease, because when kids are born with a lazy eye or crossed eye, you can reposition the muscles and you can fix it. With thyroid eye disease, the muscles themselves are abnormal. So the normal tables that surgeons say, oh, it's off by this much, I need to do this surgery, don't work. Everyone is different. They have their own table. And, it's really a bit of trial and error to see, okay, I'm going to move the muscle this much, see what happens. Are we good? No, we overcorrected. We go back. So as people end with 2 or 3 different strabismus surgeries, because it's very treat. And that's one of the reasons why Tepezza has been so helpful, but we'll get to that. There's 2 ways that thyroid eye disease can affect the orbit, the eye socket. One is by causing bulging. So your body makes more fat and it makes more muscle tissue. So the enlargement of those, when you do, causes the eye to bulge out of the socket. So some people have what we call kind of a shallow eye socket, meaning there's not a big bony cavity, a big around it, that allows the eye to come forward more easily. So Indian patients, African American patients have shallow eye sockets. We don't have a big support system to hold the eye back. So what happens is these patients bulge very easily. When you make a little, the eye goes out because there's pressure behind the eye. It doesn't like that. It just really bulges out. Whereas some patients who have really deep set eyes or really tight tissues, even though they might have the same amount of fat, they're not going to get that bulgy. Rather, what they're going to do is have a lot of pressure behind the eye. And that is manifested as congestion, ache, pain behind the eye. When you touch it hurts. So you can see this patient has just this redness around the eye. It's just swollen. It's tight. And if you put your finger, your thumb on her eyeball and you push, you'll feel a lot of resistance. And that's because this eyeball can't come out. So it has the same problem. It's just stuck inside and everything's under tension. So those are 2 ways that the orbit can be. So I probably see about 300 TED patients a year. On average, most of those people will be quiescent already, because in the US, it takes a long time for people with thyroid eye disease to make it to the person who really, can treat them with what they need to. For various insurance, and people not knowing about thyroid eye disease, people discounting the symptoms, all these things happen. And, fortunately, because of groups like this, we're able to, empower patients, learn about this disease for themselves. I have about 50 active patients a year, and maybe half or a little more than half I put on Tepezza. A good chunk of those want to see, and these are how, how it breaks down as far as 20% tend to be mild, and most people tend to be in the middle somewhere, a few are severe, and very rarely, maybe 3 when you do someone who's actually losing vision from the eye disease. So what do these groups mean? Just so you can get an idea of what it means when someone says, oh, you have mild TED, moderate TED, severe TED. These are people who have mild TED. Mainly it means they have a little bit of bulging, maybe 1 to 2 millimeters, and they have lid retraction. So they're still miserable because they have light sensitivity and they have dry eye and grittiness and wateriness, and they can't function because of those things. Every time they go out, outside, they're wearing their sunglasses and holding their hand above their eyes. They're still unhappy, but the disease is still technically mild. So you can see, for example, this patient has a slightly bulgy left eye. His upper lid is a little bit higher. This patient doesn't have any bulging, but his lids are, obviously retracted. Same thing, a little bit of right upper eyelid retraction compared to the left. So mild TED. Moderate TED is when you start to have more of the bulginess, more of the swelling and fat growth around the eyes, and then you start to see the eye is starting to get red too, because the eye has congestion and swelling and inflammation. These patients are starting to have a lot more pain. So pain behind the eyes, pain when you move the eyes, those symptoms. Severe is when you start having strabismus, or the eyes are crossed and you're having double vision, or unable to close the eyes because of the bulging, and just everything is just amped up a notch. And then, like I mentioned, fortunately this is rare, but maybe 3 or 4 times a year I have someone who's actually losing vision from the TED. So this patient walked into my office one day and said, I can't see anything. I can just see shapes and colors. So this is someone who I took to the hospital that day, gave her medicine, we did surgery, all those kinds of things. Same thing. The patient is so bulgy, obviously she can't close her eyes. All of that pressure is squeezing the nerve behind the eye. You're losing vision. So these are patients, fortunately, that are much more rare, but these are the cases where we do surgery immediately. And, fortunately, again, maybe 5-10% of the time this happens, so not very commonly. So what are medical treatments for thyroid eye disease? So the simplest thing is to supplement selenium and vitamin D. So the dose now that's recommended of selenium is 100 micrograms. That's actually twice a day. That's a mistake, not daily. And then vitamin D, depending on your levels, you should supplement. And that's because, like I said, your body uses up these vitamins and minerals in fighting the autoimmunity, and you need to supplement so that you have more. And we know that this helps improve thyroid eye disease symptoms. In the beginning, when people are inflamed for your dry eye, you really should be on some sort of steroid drop. So it could be Lotemax, it could be prednisolone acetate, it could be mild, it could be strong, but a little bit of steroid will help calm those antibodies in your tears. And you have to have an eye doctor check your pressure while you're doing it, because the steroids can cause your eye pressure to be high. It's a balance, but you need a little bit of that steroid to calm down that raging fire that's on your eye surface. Whereas further on down the line, when it's the exposure, because the lids are thing, then you have to talk about either fixing the lids or setting the eye back, or just supplementing with regular artificial teardrops. Sometimes I give people steroid injections. So if someone is really, really hurting, and I know I want to put them on Tepezza, but I know they're not going to get their first treatment for a month and a half, because we have to get the blood work, and the scans, and the audiogram, and the insurance. Sometimes I'll give them a shot of steroid behind their eyeball, and it makes them feel better in a day. And this medicine lasts for about 6 weeks. So it's really right about the amount of time that it takes me to get their first dose or two of medicine inside. And that way they feel better. It's a Band-Aid. It doesn't treat the disease, but it helps you feel better, especially when you have a lot of pain behind the eye. And it's safe in the right hands. So this is something that I use fairly often. And this is a patient who I treated once with steroids, and I treated again. And his swelling, inflammation, everything really got a lot better. Now, once you stop, he's going to go right back to here if you don't give him something long-term like Tepezza. But temporarily, it does work. I never use oral steroids for thyroid eye disease, and I very, very rarely use IV steroids. This is pre-Tepezza. So in Europe, in Canada, and other places in the world, people still use steroids, but there's really not a rule for this, because steroids don't treat they treat the symptoms. So they will help you feel better, but the second you stop, you're going to go right back to where you were. So really, there's 2 rules for steroids. One is, if someone doesn't want to do Tepezza, or they can't do Tepezza for whatever reason, but they're miserable, you can give them steroids for a while to get them over the peak of that Rundle's curve until they start improving on their own. And then you stop the steroids, and they're better because the disease got better, not because you treated them. The second scenario is when someone's losing vision with thyroid eye disease, we throw everything that we have at them. We do Tepezza, we do steroids, we do surgery, we do everything because we want to save their eye. So those are the 2 scenarios where I use steroids. Radiation, again, is also something that's similar to steroids. It's really not used by very many people. It also is suppressing the immune system. It doesn't really treat the disease. It helps you feel better, but there are side effects, so I don't love it. Targeted therapy, which is what Tepezza is, and there are a couple other medicines like that, like Actemra, really is where our field is going and where we're able to make some dramatic changes. So IGF, that's the target Tepezza. IGF, GF stands for growth factor. Every time that thyroid antibody hits the cell in your eye socket, what it does is it stimulates this IGF. So growth factor is fat. It makes muscles. It makes all this inflammatory stuff that causes these symptoms. So Tepezza blocks this. Steroids, radiation, all those things, they're like nukes. Kill the immune system. Tepezza is a targeted therapy. It actually treats the disease, and it's the first treatment that we've had to actually treat thyroid eye disease ever. So it's really the only thing that directly affects the problem at its root cause. So one of the, facts that your doctor might be looking at is the clinical activity score, the CAS. They're probably measuring it every time you're there. It's on the forms to get approved for the medicine. It's something that you track. So what is clinical activity score? It's how hot and inflamed your orbit, your eye socket is. So this is a patient who has a lot of inflammation. Do you have pain behind your eyes? Do you have pain when you move your eyes? Is your eyelid swollen? Is your eyelid red? Is your conjunctiva, which is the skin of your eyeball, is that red or is that swollen? And then do you have inflammation of the caruncle? That's this inner part right here. So all of these are really just ways when you better you respond to medicine. Tepezza. Talk about Tepezza. Before we get to it, this is Actemra. This is probably the only other targeted medicine that's realistic to use for thyroid eye disease. I probably treat 5% of my patients with Actemra. Actemra is less specific. It doesn't target that IGF. It's an immunosuppressant like any of the other immunosuppressants for, multiple sclerosis or those kinds of problems. So when you use it, you have to be careful. You have to get your blood work every month. You have to make sure that you're not getting infections that turn into, severe things. Actemra is pretty good at making the eyes less bulgy. Pretty good at improving the CAS. It's pretty good at making the inflammation overall much better. It's not for double vision. So for patients who have a lot of inflammation, this is a reasonable option. One of the reasons I use it is if someone did well on Tepezza, but the inflammation came back. And you can't keep giving people multiple rounds of Tepezza. You have to do something long-term, right? So this is a medicine that's been around for a lot longer. It can be given like insulin or Ozempic as a pen in your house. And we have a lot more flexibility with the insurance company as far as how long we want to treat someone or at what interval I want to treat someone. I don't have to treat someone every 3 weeks. And I can treat someone for much longer than 6 months if I want to. So I can treat them once every month, once every 2 months, see how they do. I have a lot more options. When you do, important for people who have really severe disease that lasts a long time, that doesn't follow that typical 2-year time frame. I mean, if someone's having problems for 3 years, 5 years, you really need a long-term solution. It's rare, but this is a really great option for that. Tepezza is really great. Like I said, when you do the game, it's really good for inflammation, it's really good for bulging, and it's really good for double vision. So the number one reason why I give people Tepezza is when they're having double vision and their eyes are stiff, because there's nothing else currently that will make their muscles smaller better. Not steroids, not surgery, nothing else will be able to reverse that double vision other than Tepezza currently. So I looked at my 120 patients that I've treated so far with Tepezza. Wish this thing was another way. You could see the side effect profile. The side effects are pretty reasonable. Most people have muscle spasms. Most people have tiredness. Most people have stomach upset. All of those things get better. The blood sugar is commonly elevated in people who have diabetes, and it usually tends to go back once you're done. The hearing risk can be differentiated into 2 compartments. One group is younger patients who get popping in their ears or ringing in their ears, or they hear their voice sounding funny inside their head. That's infusion related, it's temporary, and it tends to go away. Older patients, usually 65 plus, who have especially pre-existing hearing problems, can actually have a reduction in the hearing. So it's rare, about 5 to 10% in my 120 patients. And now, as we learn about the medicine, we've changed how we administer it. So now I get a hearing test on every patient, an audiogram before we start. And if it's someone that I'm really worried about, I get a hearing test every 2 treatments or 4 treatments. And we see, are you having a change? Are you noticing something? What's going on? And when we have that kind of data, we can decide, oh, you're 4 treatments in, you're having a little bit of hearing problems. get what you want out of the medicine. Is your bulging better? Is your pain better? How are you doing? Keep going, to stop. There's a nuanced decision to make, because with this, it's not that you wake up and you're deaf, it's dose related. So that more medicine you get over time, that's how the hearing problem happens. Now, fortunately, we're working on the we'll talk about this later, but my office is one of those sites for the subcutaneous Tepezza trial. So subcutaneous meaning like insulin, instead of in your arm as an IV, you just give it to yourself with a pen, like in your hip or your side. And the advantage with subcutaneous medicines is that you're not getting a big load of medicine all at once inside your bloodstream. So you don't have to give as much. You don't have to give a high dose that can potentially have those hearing toxicities. You can give a lower dose because it's stored in your fat. It slowly goes into your bloodstream. So you can have the same effect without having that high peak that's going to cause the side effects. So these are all things that we're working on, and hopefully we can reduce that risk even further. And then the last thing that's kind of peculiar to Tepezza is that women who are still having periods can skip periods sometimes for their whole treatment course. And usually it comes back. I should say, for my patients, it's always come back. The longest it took a period to come back was maybe 6 to 8 months, but it came back. There's no known fertility risk with Tepezza, but it does disrupt the menstrual cycles temporarily. And here are some examples of what Tepezza can do. So again, this is the number one reason why I like people to get Tepezza. You see that big muscle that's pulling the eye down, and then after Tepezza, you can see that the muscle is mostly back to its normal size. It's not quite as good as this one, but it's mostly there. So that's something that's unachievable with any other treatment, and that really will improve someone's quality of life if they can look down and read or walk downstairs without seeing double vision. As a whole, for most people, improves your thyroid eye disease by 50 to 70%. It doesn't cure it for most people, but 50 to 70% improvement is really profound, and it really will improve people's quality of life very quickly. These are people who, in my practice, got Tepezza, and I put down here how many treatments they got. So she got 4. She was mostly back to her baseline, and she was happy. This patient, you can see this eye is pulled down, and now the eyes are straight. That's a huge win, because again, he was seeing double, he couldn't drive, and now he can read and drive. And he's still a little bulgy, he still has some puffiness, but he didn't want anything done about that, and we left it alone. This is a patient who had probably 50% improvement with Tepezza. So she's really hot, inflamed, swollen, puffy, all that stuff. You can see how much the bulging has improved and how much the swelling has improved. So that kind of glassy look on her eyes, that's called chemosis. It's swelling on the surface of the eye. So you imagine every time you blink, if you're blinking against a swollen eyeball, how uncomfortable, irritating, light sensitive, tearing, gritty, feel like you have sand in your eye all the time, and now that swelling is gone. 120. His eyes were stuck looking straight ahead. He couldn't move his eyes in any direction. And after treatment, he obviously had a big improvement in his bulging, but he was able to move his eyes again. And I always like to, look at people's old, because it helps me an idea of where people were before all this started. And, again, after 4 treatments, we got where we wanted, and she was happy. Same thing. This patient needed extended treatment. 120 get her where she needed to be. And like I said, we're doing the subcutaneous trials. So we're trying to advance the field and make this medicine safer for people, easier to administer, so that you have to go to an infusion center. You can do it at home, like an EpiPen or something. And we're working on these kinds of things. So hopefully the treatments get better, they get safer, we have more options, we have more variety as far as how we treat people, and we make the medicine more customizable, because not everyone is the same and everyone needs a different treatment path. Surgery-wise. So first, strabismus surgery. I don't do strabismus surgery. You really need someone who is experienced in strabismus surgery in adults to do thyroid eye disease. A lot of strabismus surgeons do mainly kids, and they might do an adult every 6 months or once a year or something. You want someone who has a high volume of adult thyroid eye disease strabismus patients, because this is complicated. They don't follow the textbook 120 know what to do. But with that said, you can make the eyes straight again. The problem with strabismus surgery and thyroid eye disease is that because the eye muscles are stiff, you can't give someone single vision throughout their whole visual field. You have to pick, I want them to not when they look straight ahead and when they look down, but maybe they'll still have double vision when they look to the left or the right. It's a compromise. Muscles themselves are abnormal. So however much better we can get the muscles with medical treatment first, the surgery needed is going to be much better afterwards. Lid retraction, so the lid is too high and we drop it. That's done usually in my office under local anesthetic. So I have people awake, I have them sitting up, and I release the muscle little by little. I have them open their eyes, blink. We see how low it goes. And it's a very finicky thing because your eyelid is immobile. You're going to blink 1,000 times between the time we do the surgery and the time you go home. So there's a lot of nuanced, and we just have to lower it a little bit, see how you do, lower it a little bit more. But fortunately, you don't need to be under anesthesia. I still think setting the back or orbital decompression is the most important 120 debilitating most people who have thyroid eye disease. So as I mentioned, Tepezza will get you maybe 50 to 70% improvement, but most people who finish Tepezza still feel I'm better, but I'm not completely where I was before. And we'd like to get you, if possible, back to where you were at baseline. So a lot of times we'll do Tepezza first, get the inflammation out of their eye socket, get some improvement, and then we do surgery afterwards, and we can get a lot better. The advantage of doing Tepezza first, number one, is that people can have surgery sooner. They can get back to their base 120. So if we don't do Tepezza first or Actemra, you have to wait 2-3 years to make sure the disease is stable and quiet before you do surgery. If you do Tepezza or Actemra, you can probably do it in 1 year or a year and a half because the disease is treated with medicine. Secondly, the amount of setting the eye back that I have to do is a lot less after a medicine like Tepezza. So instead of having to go 8 millimeters back, I can get half of that with medicine and half of that with surgery, which means the surgery is much safer because I'm doing less. And then if I can improve a lot of the symptoms with Tepezza, then by the time I do surgery, I can really focus on, let me also improve the aesthetic appearance. Let me look not just at getting the eyeball back as much as I can, but let me also focus on the lids and the face and all of these other things that are affected by the Graves' disease to kind of get you back to that picture that you had before. And, now we're able to combine all sorts of, treatments. Blepharoplasty, this patient, this is interesting because her whole face has this convex appearance. The eyeball is in front of the brow and the eyeball is in front of the cheekbone. And she has the appearance. And with the surgery, I did a few things. I evened out her eyebrows. I set her eyes back. I put fat in her face in a few spots. I put an implant on her chin, really to make that whole profile kind of that straight line so that everything looks more harmonious. So we can focus on those like tiny little details and nuances that we weren't able to before because we were just thinking about, how am I going to get the eye back as far as I can? And as I mentioned, really it becomes much more of like an aesthetic surgery. We're not just focused on pain and proptosis. We're also focused on how do you look? How do you feel? How did you look when you liked how your eyes looked? Did you have almond-shaped eyes? Did you have round eyes? These patients had some fat sculpting, implants maybe, blepharoplasty, some of them had facelift. But again, the goal is to get you back to that. And, we do our best, and we're able to do our best because we have pre-treated you for the inflammation with medical treatment. So it really is one of the more rewarding surgeries that we do because it kind of mixes the art and science, and we're able to really, tailor the treatment to each person specifically. And in the future, what I'd like to do is, number one, if someone develops hyperthyroidism, figure out a really specific way to see, are you someone who's going to develop thyroid eye disease? And if you do get it, maybe you get an IGF pill. Maybe you get something that prevents you from developing the eye disease in the first place, because that's much better than treating you after the fact. And then the last thing we'd like to do is kind of reverse scar tissue that's already happened in the eye socket. So these are things that we're working on. The first two are already under development. We're studying the gut. We're studying the soil. We're studying all these things to figure out how people develop eye disease. We're working on medicines and different ways of delivering medicines to prevent people from getting thyroid eye disease. And then scar tissue is really hard, but hopefully we'll have, more treatments for that in the future. So, turn it back to you, Olivia.
Wonderful. Thank you so much for that fantastic presentation. I think we're going to go ahead and have a seat here. And so I want to dive a little bit, into the kind of patient experience. We've talked about some of these things in your presentation, but, one of the things that we hear a lot from patients, and I think one of the things that you mentioned is the amount of time it can take to get to a diagnosis. It's usually lengthy. It can be complicated. It can take years. It's often not a linear process, but maybe you can talk a little bit about what that, journey often looks like and how that kind of complicates, the things on your end when you're a treating clinician.
Yeah, my pet peeve is when people say, my doctor, be it your eye doctor, your endocrinologist, whoever it is, my doctor said I didn't need treatment because my disease was not bad enough. And there are a lot of treatments, not just Tepezza or Actemra, treatments that you can give to people who have a milder disease because still suffering. But I think number one is just acknowledging that regardless of the clinical severity, people still have symptoms emotionally, psychologically, cosmetically, all of these things that can and should be addressed.
Absolutely. Thank you. And, as you mentioned earlier too, people are often dealing with thyroid eye disease for a while by the time they make it to you. And so beyond kind of the improvement of the condition, are there kind of other things that you've seen when you've been able to give a patient a diagnosis or a treatment that you've seen kind of impact a patient?
Well, I think a lot of times, sometimes people don't know that they have thyroid eye disease, or they've heard about it and they've been told, well, maybe you have it, but it's nice to know this is what you have. This is what 100 people like you have been through over the next, and that this is what you're going to go through over the next 2 years. It's nice to have a roadmap and say, like, I told someone who newly developed thyroid eye disease, I saw him 2 hours ago. I told him, by summer of 2026, we're going to get you back 90% chance to where you were before. And it's nice to have that target. So,
absolutely. Yeah. One of the kind of unfortunate realities that we realize a lot in the advocacy space, and I know you probably see this too, is that, when we have these treatments that are approved, it doesn't always mean a patient can actually access the treatment. There's often a lot of barriers, things like prior authorization, things that kind of get in the way and create these very long delays. And so I was wondering if you could maybe talk a little bit about what kind of goes on maybe behind the scenes a little bit as a clinician, when you're trying to get patients their treatment.
I think that one thing is to find a physician who cares about the disease. Because if you go to someone who treats maybe 5-10 patients a year, they're not going to have the setup to take care of people efficiently, and the paperwork gets lost in the mix. So I know a few surgeons, like I do, we have a dedicated staff member for thyroid eye disease, for Tepezza approvals, for the trials, for answering these thyroid eye disease related phone calls, because you want someone, I'm doing surgery, I can't follow up with the insurance company. I have someone whose only job is to make sure that people are getting the medicine that they needed. And I've never not been able to have someone treated, whether it's a second course or whether they're uninsured or whether they were undocumented and they happened to be here and they developed the disease and ended up in the hospital. I've been able to get medicine from the company for people who need it. So I think it's just a matter of having the effort and having the process within your office to do that.
Yeah, that's fantastic. I mean, having a clinician be an advocate for their patient is such an important part of this. You're the one, as you've mentioned, who is, often the initial one to kind of give this diagnosis to people, and there are a lot of questions that, what are some of the resources that you send for patients, for families, for care?
I have a whole section on my website for thyroid eye disease. Pretty much everything I said today is on there with pictures. I know a lot of people have little ebooks out there. I think the main thing is just having this. The Facebook groups can be a little bit dangerous because you get good information and bad information, but you want to find people who've been through it, and those are probably the best people to kind of tell you, oh, this is how Tepezza was, this is how surgery was, this wrong, oh, you have light sensitivity too, that's common, this is what I did. I mean, I think that really is probably the most helpful thing that I've noticed, and that's really the last 2-3 years, the social aspect of thyroid eye disease has really taken off.
Yeah, absolutely. Being able to kind of hear the experience from other people, knowing that you're not alone, knowing that there's people going through it. One final question here before we open it up to the audience. Any advice you would give to someone who's maybe just starting their TED journey, or, to a family member or a caregiver who's kind of on that journey with them?
Yeah. It's a long disease. It's not going to be over in a month or 2 months. You're not going to get the medicine and be immediately better. And I mean, often here come in and they say, okay, I have TED. What are we going to do about it? Let's fix this yesterday, And unfortunately, it does take some time to get the treatment and to heal and recover, and just be patient with yourself. It's a process, but there is usually an end in sight. Really, the only thing that patients have in their control is to not smoke and take your vitamins and go to the doctor and get your regular checkups. So if you're doing all those things, you've done everything you can do. Be patient with everybody. As long as it's a good physician relationship, you should be able to get to a place that's pretty good.
Absolutely. Well, wonderful. Well, we do have time for questions here. My colleague Kayla, who's in the back there, or someone will have a microphone. So if you want to go ahead and raise your hand, and she'll bring the microphone over.
Hi, my name is Ellen. My question is, how do you coordinate the potential side effects of this medication? Are you monitoring that? Are you somehow involving the primary care doctor involved? I'm not clear on that piece.
Yeah, the only part that I don't handle is the high blood sugar, because TED patients often just, and they're highly, much better need to handle the nuances of whether to put someone on medicine to treat the high blood sugar. Sorry, blood sugar, not blood pressure. Apart from that, I personally handle all of the hearing, the muscle cramps, the aches, the nausea, 120. My office doing, because it's specific to this medicine. And, since 2020, when it was out, we've had to learn. We didn't know in January of 2020, when the first patients were getting Tepezza as an FDA-approved medicine, that we're going to have to, have these backup plans for patients who have this symptom or that symptom. Now, we have a pretty sophisticated way of saying, like, okay, if someone's having this hearing problem, is it a serious one or something that's going to get better? And this is what we're going to do about it. If they have, like, keeping them sleeping, what's the best medicine? What's the best pre-treatment? You need to give them the magnesium or Tepezza. There's a lot of things that we can do now, and it's a lot better for patients than it was 5 years ago. But I handle all of that.
Well, I guess then my next question is, are all eye doctors who suggest we come here tonight handling that? Or is that something I need to go back and ask my personal eye doctor?
So that's a great question. I think people do what they're comfortable with. So it's a matter of how many patients. Probably at any given moment, I have like 7 or 8 patients getting Tepezza at any time. So like I said, I can't deal with all of that myself. I specifically have a staff member whose job is to triage that stuff and tell me what's important. And, we have a system that we've built to take care of patients. And, advocate for yourself, or tell your physician that you're having the symptom. And it really is the prescribing physician's responsibility to handle the side effects, I think.
Okay.
Yeah.
Sure.
I have a question. Do you treat patients that don't necessarily have the thyroid eye disease? Well, let's say have had a stroke and let's say their eyeball is not the center of their eye. It's like
Deviated. Yeah. That's
just floating around.
Yeah, I personally don't treat that. That's strabismus surgery. It's also a much, it's a very different thing. With that, the nerves are not working. The muscles are all healthy and fine, but the nerves are not doing what they're supposed to. And it's a totally different treatment, even though the appearance.
So an eye doctor, I guess an ophthalmologist would handle that?
Yeah, or a neuro-ophthalmologist.
Okay, thank you.
We're here.
Hello, this is Saibal Ganguly. Question is that how's the success rate of the second Tepezza I've had circuits already. I mean, still dealing with vision. It's better, obviously, before when I started. So one of them, it has been 6 months since I completed treatment. So how's the success rate for second Tepezza or?
Yeah.
It can be.
In the beginning of the talk, I mentioned that 5 to 10% of people have long-term inflammation and reactivate. So after Tepezza, and in my practice, I find that it's the 5 to 10% of people who have severe thyroid eye disease who need multiple treatments of Tepezza. So out of 120-ish now patients that I've treated, I've had 8 or 9 patients for second round. And of those, 2 of them had flares after their second round, and then I put them on Actemra. And then they were quiet. Because again, with Actemra, I can space and treat them for as long as I need. But again, everyone's disease is different. So usually if you responded well the first time and it's just recurred, you're going to respond well the second time. 8 doses is a magic number. So 8 was chosen when Tepezza was a molecule in a test tube and it had nothing to do with thyroid eye. 120. So, I treat some people with less, I treat some people with more, and you really just have to utilize it. But it's like I said, those are the numbers. It's pretty successful.
And how long should one do treatment?
It depends on how severe you are. And it also depends on your momentum. If you got better with the Tepezza and it just recurred when you stopped, I would start it as soon as possible. Whereas if you really didn't get that much better with Tepezza, number one, I would question my diagnosis, right? Is it really thyroid eye disease? And number 2, do I have to put you on some other medicine because it's just not working that well for you? So, but if you responded well, again, like the second round.
Thank you.
Yeah.
Any other questions before we wrap up here?
Yeah. I know someone who said she had Graves' disease and she now has no thyroid. So how does that affect her chances of TED or not?
Well, it's still the bone marrow. So if your body is making those antibodies, even after thyroidectomy, people can still develop the eye disease. Most people who develop eye disease get within or before a year after their Graves' or Hashimoto's diagnosis. So if you made it a few years past that time point, it's unlikely that you're going to develop it.
I'm sorry, I'm really loud. For someone that you would say milder symptoms, do you recommend they just immediately go on Tepezza, or can they start with like a vitamin D and the other medication that you meant to see?
Selenium.
Yeah, that.
Yeah.
First to see if the symptoms will go down before you decide to do Tepezza.
I absolutely don't recommend that people immediately jump 120. It's a serious medicine that has side effects. It's a great medicine, but it should be used with care. And 2 things. Number 1, if someone is really mild, I might wait a little bit to see, are they someone who's going to get worse? Because if they are, I like to time it so that 6 months that you're on Tepezza is kind of near the peak of your disease, so that we have the best chance of only having to treat you once, and then we fix it. Number 1. Number 2, with mild disease, mainly people sometimes have upper lid retraction, and that's the one thing that Tepezza doesn't really do that well for. That responds much better to surgery. So even if you do Tepezza, 120.
Right. Okay. Thank you.
Wonderful. Well, Dr. Ramesh, I just want to say thank you so much for joining us this evening. And thank you everyone here as well for joining us. We really appreciate it. As I mentioned earlier, we have a bunch of resources on our website, visionhealthadvocacy.org. I know Dr. Ramesh also has resources on his website. But
I do want to thank all my patients who've allowed me to use your photos. So I appreciate that. So
fantastic. Well, wonderful. Thank you all so much for joining us this evening. I hope you had a good time.